all the members of the box, and all the people present here. A very good morning, very cozy winter morning here in Bhuj. We begin with the session one. Not wasting much of your time, we'll proceed ahead. I welcome all the chairpersons of the session one. Please come on the stage to chair the session. Dr. Pannaben Rudani ma'am, Dr. Shaili Chaya ma'am, Dr. Divya Hirani ma'am, and Dr. Sarfraz Kazi. Because of absence of few chairperson, I'd like to invite Dr. Nirmala ma'am, Dr. Samira ma'am, and Dr. Bhavik sir to chair the session. IUI, as you all know, is the most basic procedure which we perform in the infertility cases. IUI is a basic but still works wonders when it's done properly and in selected cases like mild male infertility cases, where there are cervical factor cases. In those cases, IUI can work wonders. To have further knowledge on this topic, I would like to invite Darshan Sureja sir. He'll be explaining on the detail about tips and tricks of IUI, how to optimize our results of IUI, how in this basic procedure also we can have an excellent result. Sir is Director of Global IVF Center, Director of Miracle Women's Hospital, Director of Jatan IVF Center, and is running one of the most successful, busiest IVF center in Rajkot since 13 years. His MBBS from BJ Medical College, Ahmedabad, MD DGO from MP Shah Medical College, Jamnagar, Diploma in Endoscopy, and Infertility Specialist. He is member of various esteemed committees like ISAR, IFS, IMA, and he's been organizing secretary in various conferences. I welcome you to session, sir.
Morning, everyone. Morning, everyone. At the outset, I would like to thank Bhuj Ops and Gynec Society and ISAR Gujarat chapter for inviting me and all our esteemed faculties and share my knowledge on tips and tricks to improve IUI outcome and cost effectiveness. We were waiting since a long 3 months waiting period, and today is the day to share my knowledge. So without wasting much time, what are the basic investigations? So we would be going just touching all the tips, not going into the detail, and how to improve. What is the practical knowledge, what we can do in our routine day-to-day life to improve the IUI success rates. The basic essential prerequisites is tubal patency should be tested before doing IUI. Male factor assessment should be done. Ovulation evaluation should be done by good transvaginal sonography, if needed with Doppler, and endometrial assessment with Doppler. So for the tubal patency, screening for tubal occlusion before starting IUI is a must, and it should be performed. At least one tube should be patent. IUI and male factor. Sometimes if we have seen many patients having poor semen count and they have undergone 2, 3, 4 IUIs. So if patient is having severe male infertility, less than 5 million total motile sperm count, moderate male infertility less than 10 million, and mild will consider as 10 to 15 million total motile sperm count of the sample. Review of literature says that none of the patient with triple sperm defect, means in the head, neck and tail, have conceived. No pregnancy was observed when the sperm concentration before swim up was less than 5 million. So, IUI and male factor sperm count more than 15 million will be having a good result. Sperm count less than 10 million, medical therapy with antioxidants. Idiopathic male infertility improves count. Repeat semen analysis should be ordered after 2 months. And if still less than 10 million count, or if already treated somewhere else, then go for IVF. Don't waste the time for the couple. And sperm count between 10 to 15 million or for IUI if not done earlier. So what are the indications, and which are the indications which we are going to get good results, and which are the indications which we are going to get poor results, means not to suggest IUI. So good results are the indicated in unexplained infertility, cervical factors if the cervix is tight and difficult to negotiate in previous IUI history, patient is having anovulatory PCOS or donor IUI. Poor results, severe male factor infertility, tubal factors, means the tubes are blocked, or hydrosalpinx in unilateral hydrosalpinx or bilateral, or history of ectopic. Pelvic adhesions are seen, severe endometriosis are the cases which are going to give poor results in the IUI. choosing the right drug for prevention of ovarian hyperstimulation and IUI. OHSS is reported five-fold increase in the gonadotropin stimulations compared to natural cycles or letrozole or clomiphene. Although less effective than the gonadotropins, letrozole were more cost-effective in IUI therapy because adding more and more gonadotropins and going into the 15 to 20% success rate cycle. So better to advise letrozole and then, if needed, add gonadotropins. Not only the gonadotropin cycles. In end ovulation, development of the single follicle by letrozole should increase the chance of the pregnancy. And in the patients having ovulatory cycles, aim of COH is to develop multiple follicles thus to improve the chances of the pregnancy. Clomiphene citrate is also helpful in certain cases of the PCOS where we can have a dual stimulation. Doses of gonadotropins in stimulated cycle according to the AMH and AFCT is decided. There are two phases of the cycle. One is recruitment of the follicles and the last part is developmental phase. So letrozole to be considered in the recruitment and injectable gonadotropins in the developmental phase to decrease the cost. So letrozole to be considered in the recruitment phase and gonadotropins to be considered in the developmental phase. So doses of the gonadotropins. So the doses of the gonadotropin should be raised if the ovarian stimulation does not result in 2 or 3 follicles larger than 16 millimeters. IUI should be kept a simple procedure. No role of down regulation with GnRH agonist routinely. But if severe stromal PCOS, patient is getting menses after 2 to 3 months, and we are seeing on the stroma stromal PCOS, stroma is more, so they need a down regulation with either GnRH agonist rarely, but we can try with OC pills to make it cost effective. There is no role of growth hormones in IUI cycles. IUI and GnRH antagonists, nearly 20 to 25% of cases of gonadotropin cycles, there is premature LH surge. So addition of GnRH antagonists at the follicle size of 14 millimeter helps in such patients with good conception to prevent premature LH surge. Do right thing at right time. Trigger when, if this is just a rough idea, if we are going with the gonadotropin cycles, the follicle size of 18-20 millimeter, or if we are going for the clomiphene citrate cycle, the follicle size is 24 to 25 millimeter, then we can trigger if endometrium is not good and all. Doppler perifollicular perfusion RI less than 0.5, PSV more than 10, and changes in the uterine PI from 3.2 to 2.5, and agonist trigger can be advised, or either dual trigger can be advised in history of poor follicle rupture, or if there are chances of OHSS, then we can advise agonist trigger, which are less used in IUI. Mostly HCG is to be considered for the trigger. IUI should be performed 36 to 42 hours after administration of the HCG trigger. Confirmation of the follicle must be done, follicle rupture must be done by the ultrasound, because sometimes the patient is traveling from far distance, and we advise that okay, follicle is not ruptured, we are going for the IUI. But if patient doesn't conceive, so for the second or third cycle, we come to know that the is there any problem in the follicle rupture or the follicle quality, so that we can change the treatment to IVF. IUI should be performed 20 to 30 hours after detection of the spontaneous LH surge. We can ask the patient to do a LH kit at home and then advise them to come on the second day for the IUI. This is the most practical thing which we encounter in day-to-day practice, that poor endometrial thickness. Follicle has grown up to 20 millimeter, 18 millimeter, but the endometrium is 6 millimeter. So there is a temptation to add estrogen, that the endometrium is lagging behind. But what are the reasons of the poor endometrial thicknesses are? One is the clomiphene citrate negative effect. So we can add that estrogen and all, but instead of clomiphene citrate, nowadays we routinely use letrozole, so that the endometrium is not that much affected. Delay the trigger. This is one of the most important thing, because sometimes as I already told, that the temptation is there, 18 to 20 milliliter size is follicle is already achieved, but the endometrium is not good, and we give the trigger and the follicle doesn't rupture, and the endometrium is not good, so the conception doesn't occur. So we can just delay the trigger and see the maturity of the follicle by switching on the Doppler. If more than 50% of the follicle is covered by the vascularity, then we can give the trigger. So call the patient on the second day, So the vascularity is not good, then we wait for one more day and then give the trigger. So sometimes addition of the gonadotropins in the next cycle, scratching of the endometrium, hysteroscopy, though it is a controversial thing, but hysteroscopy is advised if the endometrium is consistently poor. So there are chances of the tuberculosis infection or might be adhesions. So we can rule out with the hysteroscopy. And endometrial vascularity should be assessed with the switching on the Doppler. Doses of the HCG in the stimulated IUI should be 5,000, 6,500 or 10,000. It depends upon your choice, but also on the BMI or on the past history of the patients. We usually use recombinant HCG in routine practices because due to the difference in the quality of the HCG, sometimes the batch of the HCG, urinary HCGs are not good. So we usually prefer recombinant HCG. So what are the techniques of IUI which we are going to use or have more result? So position of the patient is important, aseptic precautions, uterocervical length should be assessed priorly, which catheter, soft or rigid, location of the tip of the catheter is also important. If abnormal, means cervix is tight, so USG guided to be done, quantity of the sample, how much is optimum, and post IUI rest is needed or not, or antibiotics are needed or not. These are the routine questions which we encounter in our day-to-day practice. So important precaution is measure uterocervical length by USG at the time of baseline scan, so that we can assess the uterocervical length and we do not negotiate more than internal loss and disturb the endometrium while doing the IUI. Use of non-powdered, non-toxic gloves. Expose the cervix. Do not hold if possible, because catching hold the cervix will stimulate the uterus and decrease the chances of the pregnancy. Preparation of the vagina with normal saline and avoid any antiseptic like Savlon or betadine. Inseminate just above the internal os to avoid the irritation of the uterus. Inseminate slowly over 1 to 2 minutes. Gentle atraumatic insertion is the main goal, and the semen volume of the washed sample should be 0.4 to 0.8, not more than that. And wait for few seconds, prevent reflux, and withdraw slowly, withdraw speculum, and ask the patient to rest for 10 to 15 minutes. And atraumatic transfer, all aseptic precautions should be taken, and in lithotomy or head-low position. Number of insemination, this is one of the important questions. Sometimes patient comes to us and they ask that કે સર બે IUI કરો ને તો એ result આ cycle માં વધારે મળે. But studies have suggested the single IUI insemination is less expensive with similar pregnancy rates than double IUI. So we usually avoid double IUI. What are the IUI lab secrets? Proper labeling of the semen specimen. In today's era of ART law and all, proper labeling is must. We at the time of preparation, embryologist and his assistant sees the specimen, confirm the semen specimen is of the same patient, and after doing IUI, when the clinician goes and does the IUI, he read the name, and after that the staff shows the same IUI, that the cover, catheter cover, and to the patient is also well satisfied that okay, it is my name only. Prolonged abstinence to be avoided, less than 3 days or more than 10 days. Viscous semen sample, sometimes the thick semen sample is there, so we can advise the patient to collect the semen sample in with a media in it. Semen preparation, individualize. Which semen method preparation to be advised, either swim up or double density, it is individualized and one size doesn't fit to all. High quality consumables and medias to be used. And these are the different methods to wash the semen sample, but according to the semen volume and count, embryologist will be considering that. So full bladder should be there, but if the patient is having a retroverted uterus, so we have to ask the patient to empty the bladder. Cervical mucus aspiration should be done, and target time would be probably 90 minutes from collection to insemination. Load when ready, and no free space should be there at the catheter tip. Avoid the insufflating the air into the uterine cavity, and rest for the 10 minutes, and emergency tray should be kept ready. It is like the emergency anesthesia trolley. We keep the emergency drugs on the anesthesia trolley like adrenaline and atropine. So you have to be ready with the emergency tray with metal IUI catheters or other instruments, so that if there is a difficulty in the negotiation, you can go with the ultrasound guidance with metal catheter in emergencies to avoid the failure of the IUI. What are the cancellation criteria in the stimulated IUI to avoid OHSS? An IUI cycle should be cancelled if ovarian ultrasound reveals 5 or more follicles more than 12 millimeter and 3 or more follicles more than 16 millimeter, and also advised to withdraw from unprotected sexual intercourse if the stimulation is more than 5 follicles of 12 millimeter and 3 or more follicles more than 16 millimeter. Certain special situations, recommendation in unexplained infertility, mild endometriosis, mild male factor infertility, minimum of 3 cycles and maximum of 6 cycles are recommended in above conditions. IVF is sometimes more cost effective in women above 35 with unexplained infertility, elderly women with mild male factor, or women with advanced endometriosis. So better to go for IVF, because wasting of the time and the ovarian reserve is getting more and more poor. So better to have their own egg and do IVF. Women less than 40 years who have not conceived after 1 year of unprotected intercourse or 4 cycles of stimulated IUI or for 3 cycles of IVF with or without ICSI. Women aged 40 to 42 years who have not conceived after 6 months of unprotected intercourse with provided good AMH, 2 cycles of IUI can be tried, or otherwise offer IVF or ICSI with self or donor eggs. So to summarize, how to make IUI cost effective is, according to the guideline, minimum investigations. If gonadotropin is needed, low dose type of GnRH, use urinary HMG or FSH, and clear cancellation protocol should be in hand. USG monitoring, estrogen to be done rarely, or the blood investigations for the growth of the follicles to be done rarely. HCG for ovulation trigger or spontaneous rupture can be used. One insemination in the cycle, and minimum post-wash semen concentration should be 5 to 10 million. Proper sperm washing methods, which is cheaper. Optimum number of cycles, not more or not less, and referral to the IVF unit at proper time should be advised. Thank you. Thank you for the patient listening. Yes, yes. Yes, this is the total motile sperm count. So that the motile and total count means the volume means that there would be, we are just only considering count or motility, but the volume is different for the different patients. If there is 2 ml, 3 ml, so the total motile sperm count is one of the important criteria to be advised.
Thank you, sir, for such a vivid knowledge on the IUI topic. Any further questions? If there are no further questions, we'll proceed to the second session, second topic.